Okay, I think we're just going to open this session. I'm Jan Claassen from Columbia University, New York, and my colleague, Jacques, is from France. We are going to have hopefully a very interactive session here. Our case today is a case of coma, and the idea is that you get as engaged as possible. You can interrupt us, you can ask questions. The more interactive it becomes, the better. If you have a question from your clinical practice that relates to this case in any way, please feel free to ask. All right, Jacques.
Yes, because I am sure that you have to face to this kind of case because it's always very challenging for us, challenging for the families, challenging in the ICU. Sometimes it's a nightmare. So it's a 30 years old man, a traffic accident and a severe brain injury with a subdural frontoparietal hematoma, subarachnoidal hemorrhage and a small tetraventricular hemorrhage without hydrocephalus. And facial and skull base fracture with pneumocephaly and other orthopedic fracture. So we went to the operating room and we have no problem of intracranial hypertension. And during his stay in ICU, 2 episodes of pneumonia. At day 30, the CT scan show multiple petechiae in supra and infratentorial zone. So diffuse axonal lesion. And the MRI show bilateral hemorrhagic petechiae in the corpus callosum and frontoparietal areas. And the EEG show diffuse background slowing consistent with diffuse brain injury.
Maybe oh yeah, you got
Yes.
it. Perfect. Maybe do you have questions up to now? Any
So,
questions in the audience?
At this point, the question is, coma, vegetative state, minimal conscious state, emergence from minimal conscious state, and you have to discuss with the family.
Right now it's a question what the state is.
It's a question about the state and how you can predict in your mind and the evolution, the time course of this patient. Yes?
What is a GCS and the response of the patient? I think like the definition is depend on the response of the patient, not for just the imaging. Even the imaging like the DAI high grade that we saw is a poor prognosis. But anyway, I think it's depend on the Glasgow Coma score and the response of the patient.
Okay, so it's very important point. It's a clinical examination of the patient. So you talk about the Coma Glasgow score. You are not agree? Really?
I would just like a timeline as to when sedation was stopped. So you're day 30 with that sort of injury. Did you have medical management of ICP at all? What sedatives were you on? When did you stop sedation? 3 questions there.
Yes, we have no problem of intracranial pressure and we stop sedation after 2 weeks. Okay, so we are far away from sedation. No. Yes, exactly. Oh, sorry, if there is a tracheotomy or not. No.
So Jacques, again, one just, I think, relating to the first question, what on exam, when you examined the patient, were the eyes open, were the eyes closed? Was the patient interacting with you? When you stimulate him, what was the patient doing?
We will see this.
Okay.
So I guess it's just a proposal now, what we suggest, yeah? So I would say you did an MRI and EEG, so the patient must be comatose or in a vegetative state, otherwise you wouldn't have done it.
maybe we can move. And I don't know if you are familiar with, if you know this score, but it's what we use in my unit. So is a CRS-R score. And it's a score that is largely better than the Coma Glasgow score. I don't know if you want to comment.
Yeah, maybe, and because you mentioned the Glasgow Coma score earlier, right? So Glasgow Coma score is a very, very important score that was developed in the 1970s for TBI patients. Was developed by Teasdale, and what they wanted to do is they wanted to have a score that summarizes the most important neurological assessment that predicts whether the patient was going to do bad or good in the very short term. But the primary objective was they developed it in the UK, and they wanted to identify the patients that would need a neurosurgical intervention. So the idea was, in the emergency room, in the very, very beginning, right, which patient is going to deteriorate overnight where the neurosurgeon could help. So the patient that's going to deteriorate anyhow, where nothing could be done, you don't want to get the neurosurgeon, wake him up. They have like limited resources, I hear. Also the one where the neurosurgeon comes and says, well, everything is fine. What am I doing here? You don't want to do that, right? Because the next time you give the neurosurgeon a call and wake him up, they're not going to come back, right? So you want to identify the patient where the maximum impact can be done. And so that was the purpose of the Glasgow Coma score. The Glasgow Coma score assesses the motor function, the eye opening, and the verbal response. Right? You already see the verbal response in most patients at day 30. Either they have a tracheostomy, they're intubated maybe still, probably unlikely in most units, or they're extubated and they're talking, right? So that doesn't really apply very well to that. The Coma Recovery Scale Revised was developed by Joe Giacchino, and it is a very detailed, it has 6 features. So you can see auditory function, visual function, motor function, and very systematically, it is a hierarchical score that gives you the best neurological function in that category. And combined, it gives you a composite score that correlates with the amount of behavioral evidence of consciousness. So it's been validated in many languages. It's been validated reproducible. It has very good psychometric properties. So it is a great scale. I will say, though, we use it in my unit as well at Columbia in the research setting, but it wasn't developed for the ICU. It was developed for the post-acute care, the rehab setting. And in the patients that are completely out, that do nothing, right? Comatose patients, they don't even respond. It is very quick to do this scale, right? If I'm assessing one of you guys, it is also very, very quick, right? But if you have these most interesting cases that are in between and you have to actually repeatedly do these assessments, then it becomes a scale that may take 45 minutes to assess. So in the ICU setting, I don't know in your units, but in my unit, nobody has 45 minutes of time just to do a scale, right? And also at the beginning of 45 minutes, the behavioral assessment may be different than at the end of the 45 minutes. So there's efforts right now by Joe ongoing to develop an ICU version of this. It's great that you're already doing it, and I'm doing it as well, but there's going to be an abbreviated version very soon that is targeted, tailored just for the ICU. And it's going to be much better than the GCS.
And the reason why we use it, it's because we open a post-resuscitation rehabilitation care, and we couple this unit with the ICU. So the readapt physician came every day in the ICU, and it changed completely your way to do. And it's why we use this score. 5 years ago, I have no idea of this score. Not at all. And it's very important because I think that the more we take in charge this patient, the more you are adapted to talk with the family. And most of the time, ICU guy, we don't know this. We are not good at this. Okay, so I think it's this score, it takes time to do. And this is the Neuro psychologist in my unit who perform it. It's not ICU guy. And I think it's important because it's a different, it's the same team, but it's a different specialty. And so I think it's a good combination.
So that's the highest level of evidence that you can get. That's really, really spectacular because they're not biased by what they just did, right? It's called sunken effect bias. If you have invested a ton of effort on a patient already, you're much more biased to think that the patient is doing better, right? So if you have an independent person evaluating the patient, that's spectacular. Yes. Can we go back to the slide before for 1 second? Just a question, does everybody know what terms, the one before that, the one with coma, vegetative state, does everybody know what these terms mean, or shall we, any questions about that?
If you can explain, it will be great, because it's not easy to catch.
Yeah,
and
so
it's very important to have a clear explanation of the words, wording.
So there's behaviorally defined states, right? So coma is a state after acute brain injury where the patient, it was first described by Hippocrates, so a long time ago, right? But a patient looks like they're asleep, but they cannot be awakened up from this state. They don't open their eyes, they don't have purposeful movements, and they don't follow commands. If you're in a vegetative state, originally that was described in the 60s, and it was thought that it was always after a long time and that it was permanent. So you will see the early publications call it permanent vegetative state. After we followed patients for longer times, we now know that it's not necessarily permanent, but those patients start to open their eyes. They may have some sleep-wake cycles, if you do EEGs, for example, but they don't follow commands. They don't interact with you. And the minimally conscious state, that was one of the other things I think that you had listed there. The minimally conscious state are patients that are not fully following commands. There's a minimally conscious state minus, where the patient may look at you. You may have encountered this as well. You walk into a room, you ask the patient to do something, they don't do it, but they follow you with their eyes. Or when you call their name from one side of the bed, they look at you. That's minimally conscious state minus. Minimally conscious state plus is a state where they may show some verbal understanding of commands. You ask them, stick out your tongue. They do it, but they don't consistently do it. It's not reproducible necessarily. So that's MCS plus. Why is it important to define these states? It sounds like very terminology driven, but it's been shown that if you are in one of these states, the higher you are, the more likely you also have a chance to recover much more later on. So it predicts potentially, the exact definition of what state it is, predicts the further recovery of function. So that's why it's important to define this.
And it's very important to repeat it. It's why I put all the evaluation, because you can see that clearly at what point there is a change. Okay?
Another important thing about this, which is amazing, right? You can see day 27, day 90, day 120. When I first started training in neurocritical care and critical care in the 90s, late 1990s, and I remember my teachers, they told me, I got a young patient exactly like this, 30-year-old patient, with TBI, is in a coma. If they haven't woken up by 1 week, they will never wake up. We now know that that's completely wrong. Patient may have actually delayed recovery, and it's not rare. You have to give them the chance to show the recovery. Back then, my older teachers, they were always right, because after they said they had no chance of recovery, care was withdrawn, and of course the patient didn't recover, right? But you have to give them a chance to show the recovery.
Exactly. So
in terms of, we heard a couple of things about imaging and EEG early on. Yeah, go ahead.
just wait.
I know, I'm sorry. Are you doing CRS on tilt table as well? So our practice is to tilt table and do the CRS where you've got that minimally conscious -1 state.
CRS.
The CRS on what? We don't. We don't.
Yes.
Yeah. Yeah, that's not really practical for us in the ICU, but it's interesting because you may, but it probably, whether you get a change will very much depend on what the underlying etiology is and the reason why the patient may actually have impairment of consciousness. So in somebody, for example, with low pressure hydrocephalus or sunken flap syndrome, then you may actually see a difference, but otherwise you don't. Yeah.
How do you use or how do you interpret the usefulness of the 4 score,
So
which we use in
Yeah.
our unit? And the second question is, Stephen Laurie just talks about an unresponsive wakefulness. How do you interpret this term?
do you want me to take that?
No. Oh yes. So about the 4 score, it's the value of the 4 score is less, and so we make the choice to use only 1 score and sometimes the 4 score it's more convenient for physician. And the idea is to say, okay, maybe we go to the 4 score because it's easier to perform for physician or nurses. I think I'm not confident with this because I think it's very great to have somebody inside the team but outside the team.
So that's one thing, and then the 4 score is conceptually, you can compare to the GCS. So it's also a score developed to predict poor outcome, right? So, and it's actually pretty good. It's better than the GCS. It's not a question because especially the respiratory function is very nicely detected there, and also the pupillary response is in more detail captured there. I think the 4 score is better than the GCS, but it doesn't detect consciousness. It's sort of a composite score for detecting the severity of the illness and predicts outcome pretty well. So we do detect that as well. We record that as well, but it doesn't replace the CRSR.
10 years ago, it was the only score.
Yes. No.
And then your second question was about the unresponsive wakefulness syndrome. So that is this. It describes exactly the same phenomenon. It's just a different term. The reason it was sort of developed, I think, is because vegetative state has a negative connotation for some families. It sort of, it doesn't, I mean, for vegetable, people that talked about that. So that's why it was developed. I think if you just think about the word, it is not as precise as vegetative state. So unresponsive wakefulness, because those patients can actually be unresponsive. They're not interactive and they're not conscious. So I don't think it's a perfect term. I do understand, though, and do recognize also the limitations of the term vegetative state. So it's sort of like, typically in most papers, at least what I do is I write VS/UWS, but...
You have patients in coma who don't respond to anything, but they have a wake EEG.
Yeah, exactly. No, it's a great question. So you put up this. This is just so somebody mentioned imaging and EEG, right? And the only reason we wanted to put this up here is to say if you're examining the patient, right, there is a very diverse underlying endotype that can actually be the reason of the presentation of the patient. So even in a patient with TBI, this was a paper where they looked at CT scans in patients with TBI, and it's a very old study, but I think it's great because those patients all looked exactly the same, right? They all were in a coma, and they had, I forget, but a low GCS, below 8. And you can see the underlying reason why they're in a coma is very different. This patient has an epidural hematoma, a contusion and hematoma, there's diffuse axonal injury. And why is this important? One, it may be prognostically important what the reason is for the behavioral expression of the exam. And secondly, it may actually require different interventions. The epidural hematoma may require an emergent intervention by the neurosurgeon, whereas the diffuse axonal injury is going to be treated very differently. So this is just, it's an important, imaging is very important. Even CT imaging. MRI obviously has additional abilities. It can look at structural integrity and structural connectivity throughout the brain. It can even look at functional connectivity. And then maybe we go to the next slide. The other thing was EEG. So you can have somebody, you heard in the presentation, it said EEG consistent with diffuse axonal injury, diffuse brain injury, I think it said. It's a very nondescript term, right? But what this can relate to, this is not the EEG of the patient, but just to illustrate this, a normal EEG looks like that, right? Front to the back. And you can see here there's an alpha rhythm in the back, that's what this is called, a higher frequency, a mix of frequency. And patients with diffuse brain injury may have this diffuse slowing. So these are slow waves, these are called delta waves, right? Why do we get an EEG? One, it can have prognostic information, but it can also detect seizures, for example. And if a patient has seizures, that's a potentially reversible reason for the bad exam. So once you look at the patient, it's most important to very precisely identify the behavioral phenomenon. That's by categorizing the patient along these categories that we talked about, and then to go beyond and search for why does the patient have this behavioral state. And imaging as well as EEG can help you there.
Do you have a question on this? No, that's okay. Yes?
What do you think of non-cortical seizure activity, myoclonic activity as, a prognosticator or as something, should we try and treat that or no?
So that's most seen after cardiac arrest and hypoxia. It's very, very common, right? And so it is actually in practice not so straightforward to distinguish between the cortical and subcortical myoclonic seizures or phenomena. You actually have to do back averaging if you really want to do it. So the reason I'm saying that myoclonic status epilepticus should be treated at this point in time. And that can be potentially reversible. If you have subcortical seizures, those don't impair consciousness typically, but they are actually also may contribute to worse outcomes because patients may have muscle breakdown. I had patients that had so frequent peripheral myoclonus that they actually had renal failure caused by it, right? So there may be other reasons to treat this. In terms of using it as a prognostic sign, it is in the old days before hypothermia, it was invariably associated with poor outcome, so people used it for that. We now know that some of those patients, if treated aggressively, can actually recover, but it's still not a good thing to have, right? So you can still, when you talk to the family, it's better not to have it, but it doesn't mean that it's absolutely impossible that the patient will have some recovery. I had a patient, for example, that had a cardiac arrest on a treadmill, and he was actually a physician, and had a cardiac arrest on the treadmill, had prolonged ROSC time, was then treated aggressively at myoclonic status, and he's practicing now as a neurologist again. So it's sort of like it's possible, but I tell you, I had hundreds that didn't have that, right? So.
How long is prolonged? How long was it
for what?
For ROSC?
For coma or for
ROSC? For
ROSC.
that patient.
That's also a very good, very, very good question. So it's I mean, in practice, honestly, I think ROSC time is often very imprecise because most of the time nobody is there at the time when the patient loses the pulse, right? At least in New York, it's sort of always very often an estimation, right? But if it's above 30 minutes, I get more concerned. Below 30 minutes, I think that doesn't mean everybody below 30 minutes is going to do great, and that doesn't mean everybody above 30 minutes is going to do badly. But that's sort of in my mind how I have that.
So the patient went to a chronic vegetative state POSI relational state unit, and the family asked for an expertise in a specialist center. And you can see that in this center, they perform an EEG, a continuous trace with a little fluctuation, with composed of activity of alpha band, monotonous, poorly special, and no reactive to different stimulation, absence of epilepsy, absence of metabolic encephalopathy. and the cognitive evoke potential cortical response to stimuli, presence of global effect marker of awareness, and a significant contingent negativity. So at the PET TDM bilateral hypometabolism of the temporal and parietal cortex, severe bilateral hippocampal hypometabolism, and the MRI show an increase in hemorrhagic petechiae suggesting diffuse axonal lesion and subcortical atrophy and tetraventricular dilatation. So for an ICU guy, when you see this, wow. So what is your interpretation of this?
So, first of all, if I go through this, right? So there's nothing treatable with antiepileptics, right? There's no epilepsy, no seizures, no status. So you can't improve this state with giving antiepileptics. That's important because antiepileptics have side effects. Often we feel like, what's the difference? But many antiepileptics can also depress the mental status. So that's the first thing I look for in the EEG, right? This sounds, I didn't look at the EEG, but this could be alpha coma, right? So that's an unvariable state. That is actually not a good thing to have. It's better than having no responses in the brain at all, but that's not a good prognostic sign. This is non-specific metabolic encephalopathy that can be from the renal failure, that can be from all sorts of things, from an infection or from underlying brain injury. So I don't put too much weight on this. This is a very interesting test. It's a whole set of different studies that we can do with electrophysiology. It basically means you confront the brain with a stimulus. This can be an electrical stimulus, this can be an auditory stimulus, and then you analyze the brain's response to that. So classic thing is, for example, in the oddball paradigm where you have frequent and rare tones, you can actually detect, even without asking the patient what to do, you can detect whether the patient is trying to understand this signal. So that's basically a signature of consciousness. You can do other things. For example, one study we did is we put headphones onto the patient and we asked the patient, move your right hand, and then recorded the EEG while we're doing that. Then stop moving your right hand. And we did this over and over again. Took the EEG and analyzed it and looked at whether systematically the EEG response after the move compared to the stop move command was different. And that's called covert consciousness or cognitive motor dissociation. And we found that 15% of the patients that looked like they were completely unresponsive actually were conscious. And that related to long-term recovery. So it's clearly, with tests like this, you can detect something that's it's under the hood. It's under the patient is there. You can't go to the bedside and detect this, but you can potentially detect these signals there. PET shows you the metabolic activity. It's a correlational approach where you say, well, a group of conscious patients or patients that are going to do good, they had this PET metabolic activity. Therefore, we think this patient is also in this state and may have a better recovery. It tells you potentially very important information about brain metabolism. And then MRI is interesting because you can look at one, I mentioned it briefly before, you can look at pathology, but you can also look at the structural integrity of the brain. So we now know that much of the function is not like what we thought in the old days. Here in the front, we have our social awareness. Here we have this function in the brain. Much of it is a network of brain areas, right? So even moving your arm requires coordinated activity between large areas of the brain. To allow that, we have to have first structural integrity of these networks. And you can test that with diffusion tensor imaging. So there's some very nice studies looking at utilizing DTI images. There's a great study from Paris, for example, from Louis Poiracet, where he looked at cardiac arrest patients, did DTI studies, and was able to predict very accurately the chance of recovery and the ultimate outcome. So these structural imaging techniques may actually be important for predicting outcome. And then there's also functional MRI techniques where you, similarly to what I told you about the EEG, you put headphones onto the patient and you ask the patient to do something. And the first study, this was by Adrian Owen, first discovered, where he asked a patient with TBI, the first patient was 6 months in a vegetative state and was a young woman, very similar to this case actually, after a motor vehicle accident. And he asked the patient, imagine walking through your apartment, and then imagine playing tennis. And this patient activated exactly the same brain areas compared to healthy volunteers. And so there was evidence that we don't know how conscious the patient was, how much she understood, what the full cognitive function was, but we know that the brain activation was very similar, and on some level, she understood these commands. So that's what you can do with imaging techniques.
But are the different technique very strong to predict the improvement of the patient?
So they don't predict in isolation, but they actually, in multivariate analysis, there's some studies now coming out where this information is integrated with, of course, age predicts the recovery, right? The chance of recovery. Your injury mechanism, your injury sort of load, that predicts recovery. Your baseline neurological exam, if your GCS was 3 versus a little bit higher, that also associates. But even if you take all of that into account, some of these emerging biomarkers for predicting recovery actually still stand up, and they may predict long-term recovery.
Do you have a question on this? Yes? Sorry.
Yeah. Is the patient still in ICU, 200 days? Yeah? Right, so obviously the tube is out, and
Yes.
did he have a trachea or?
No. Yes?
Can I ask at what stage you use pharmacological stimuli like amantadine in your assessment?
So that's a great question. So there's probably the best study on this is by Joe Giacchino, again, that I mentioned with the CRSR earlier, right? So he studied patients after TBI in the subacute phase. I think it was about 3 months after the injury, and started amantadine in those patients, and was able to show that those patients that had amantadine had an earlier improvement on the CRSR, on this behavioral scale of consciousness. So there was an effect. Once he stopped the medications, the patients actually had the same recovery. Would he have continued it? I think he had it in for 2 weeks. Would he have continued? It's a question whether those patients with amantadine would have continued on a better trajectory, or whether those curves would have ultimately come together. However, we know that time to recovery of consciousness is super important, right? Because very often, still early on, decisions are being made about goals of care and things like that. So if you can even shift the recovery, even if all of those patients would recover, if you can shift this by 1 week or 2 weeks, would be hugely important. So that's the best data out there. There's a couple of other pharmacological approaches that are being developed and are sort of in smaller proof of concept stages. There's electrical stimulation, for example, of the central thalamic nucleus. There's magnetic stimulation of the brain. There's a number of different approaches, and I think we're only at the beginning of seeing what's going to happen. Anecdotally, what I do, I often start amantadine. And there's always this concern, could it lower the seizure threshold? Could you do harm? That wasn't seen in Giacchino's study, and I've actually not seen that as well. We did sort of a cohort study where we looked at that, and it seems to be actually safe to do that. Typically, just to be sure, I put the patients on EEG just to be sure that they don't develop seizures.
May I ask a question about the prognostication-wise? You mentioned an exceptional case about more than 30 minutes downtime, and then the myoclonic seizures, and then successful recovery. Was there anything specific or outstanding you remember on that case which make him different? It might be something.
Yeah.
So how much he was different from the responsibility to anti-epileptic seizures, or et cetera, et cetera. So and how quickly he recovered to the state he was able
it's
to
a great
walk out
question.
of the hospital, perhaps.
Right. It's a great question. So, of course, I was surprised to see how good he was doing. He wasn't doing good immediately, right? So it took quite some time. What was different, maybe different to some of the patients I see, he was very functional before he had the treadmill injury, right? So, or the cardiac arrest, because I think it is different if you are already in a nursing home, you're bed bound, and then you have a cardiac arrest. It's very unlikely that they're going to get the patient better than they were before, right? And even to reach that is pretty hard, right? So that may be on a cohort level, set him aside. But I've definitely seen many other patients that were in this state and didn't do so well. But I've also seen, no, he's not an isolated case, right? I've seen actually quite a few. I think one of the differences, one important thing maybe to mention in this context is the Telstar study, right? That was, I think, published last year in England from the Netherlands, where they actually had patients with cardiac arrest, and they were randomized to aggressive versus less aggressive treatment, and they didn't see a difference. What's very interesting is if you go to the supplement, and this wasn't powered for it, so they cannot really make lasting conclusions about that, but they had combined patients with periodic discharges, so like generalized discharges that were always the same, like as malignant patterns, as well as people with myoclonic seizures or status epilepticus. And the patients that had seizures and status epilepticus seemed to be doing better with the intervention, and the patients with the just generalized periodic discharges actually seem to be doing worse with the intervention. So it might be more, it was very difficult to do the study to begin with, to even get enough patients for this, right? But there might be a signal there and some important information about that.
Okay.
Sorry, just regarding the amantadine, just one quick more question, because all the information we have is in the subacute phase. How early would you actually, be brave enough to use it still in the ICU?
I wait probably, it depends a little bit on the underlying etiology, right? So, but typically, if they have any seizures or epileptiform patterns, I don't do it very early on, but otherwise, within the first week. Yeah, relatively quickly. Yeah, not if they're acutely, for example, if somebody has, let's say, subarachnoid hemorrhage is in acute vasospasm, I don't do it, right? Because it complicates the whole picture. If somebody has TBI and has ICP crisis, I don't do this, right? But if they have stabilized and they're in a steady state to an intensivist impression, and they're still not waking up, and I don't have a good other explanation, I give it a try. I talk to the families though, all right? I tell them that there's not good evidence for this and whether they would be interested in pursuing that. Yeah. It's not a clinical trial, right? And obviously, as an investigator, if it's just looking at your own practice, you're always biased towards thinking you're doing you're the best. So it's so I think I would say there's enough evidence for me to think that we should look at this in a more systematic fashion, but it's too early to say.
Thank you. My question is about prognostication and the impact of different ways of getting the prognosis in a better way. But the problem for me as a clinician is that when you get out of the acute phase, where treatment withdrawal is not an option anymore, you will be waiting, especially for a young patient with traumatic cause, waiting to see if they are getting better. And the question for me is not, is the person conscious and is he going to recover? But the more relevant question for me would be, is there a way for me to be sure that the patient will never recover and will never regain consciousness? And you present some tools to affirm consciousness, but do you have tools or a combination of tools to affirm that the consciousness will never be regained? Which would be, in my opinion, more useful to my clinical practice.
Yeah, it's as difficult as predicting recovery, quite frankly, because it is so many things that can affect that, right? If you just think about somebody with cardiac arrest and you predict that they will not recover, or that they would recover, but then they have a second cardiac arrest, right? Of course your assessments will not have predicted that unless maybe the cardiac exam, right? So I think it is difficult, but I agree with you 100%, because in terms of resource utilization, it may be actually even more important to identify the patients that have no chance of recovery at all. What we know now is that patients, if you look at patients that leave the hospital unconscious and you follow them up, a year later, a large number of them have recovered consciousness. A large number. It's like it's much more likely than not having recovered. So it's, obviously there's a bias because all the patients that were felt have no chance of recovery probably were withdrawn up on already. But when you talk to the families, there's a pretty large chance that they will recover. And then how to predict the ones that don't recover is much more difficult actually. So it's a great question.
Jan, it's you talk about resource, but it's not only a problem of resource, it's also a problem of what quality of life we not give, because it's not the good word, but the patient will have. So it's, I think it's why it's very important to try to know if we are sure that the recovery will not be an option. So we know all it's very difficult, but it's really a big ethical problem.
There's actually studies that now look at not just recovery of consciousness or recovery on these. Most studies have used Glasgow Outcome Scale Extended, for example, for TBI, right? But it's super crude, right? It doesn't really tell you how happy somebody is. So there's a lot of effort put into quality of life, or even like functional assessment, reintegration into their life from before, return to work, for example. And one interesting aspect is that if you look at the patients that recover consciousness, they 20% go back to work or their prior activities. So that's actually not impossible, right? So it's pretty high. However, there was a recent study published, I think was this year, last year, in JNNP from the Center TBI cohort, which is doing an amazing job, right? Looking at long-term recovery of after TBI. And they looked at comparing quality of life and Glasgow Outcome Score. Glasgow Outcome Score is basically functional independence. Very crude, just how much support you need. And the patients that had actually better recovery on the Glasgow Outcome Scale Extended, not rarely actually had worse quality of life. So that speaks to exactly what you're saying. We actually have, or what you were saying, we have to also look at quality of life and try to predict that as well, and not just these crude outcome measures.
Thanks a lot, and thank you, Jan. It was great. So have a good evening. Bye-bye.